Dear colleagues, good afternoon. Let me first thank the organizers and in particular Dr. Siderova for the invitation to speak once again at the Moniki conference. I would have loved to be physically present, but circumstances have made it difficult. This year, I've been assigned the task to discuss the role of muscle MRI in the evaluation of treatment of spinal muscular atrophy, SMA. SMA being much more than a muscle disease, I shall also review the role of MRI in the evaluation of other target organs and, of course, with a special attention to the spinal cord. I have no link of interest to declare in relation with this talk. Motor neuron disease is a very large family. Diagnosis, including 5Q SMA, can almost always be reached with the combination of a careful clinical examination, electrophysiology, and nowadays genetics. So the diagnostic role of imaging in motor neuron disease is limited. That doesn't mean that it has no role. To the contrary, in modern medicine, imaging is more and more viewed as a biomarker to characterize the target organ involvement, to monitor disease progression in these target organs, to evaluate the response to treatment, and even to assess the safety of procedures. So the imaging role, and particularly MRI in motor neuron diseases, far from shrinking and vanishing, is expanding and will become more and more important. In motor neuron disease, the imaging can be used to evaluate the first motor neuron, the pyramidal tract, the second motor neuron in the spinal cord, then the peripheral nerves, and finally the effector, the muscles. And let's start with the muscle. Just as a reminder, in muscle disorder, our imaging essentially characterize the muscle trophicity, the presence and extent of chronic degenerative changes, mainly fatty replacement, and also what we call disease activity, which is revealed by increases in muscle water T2 or hyperintensity in STIR-T2 weighted sequences, and largely reflects the intensity of the underlying pathogenic mechanism, edema, inflammation, necrosis, or dystrophy. Muscle trophicity and fatty replacement can be estimated with ultrasound and CT, but it's only with MRI that disease activity can be properly assessed. That makes muscle MRI the preferred imaging modality. The evaluation of muscle damage by MRI can be either qualitative with T1 weighted and STIR-T2 weighted sequences, or quantitative with Dixon and water T2 maps. For longitudinal studies with therapeutic intervention, it is only the quantitative approach that can objectify changes and is consequently mandatory. In acute denervation, the key feature is the expansion of the incestation due to the rapid shrinking of the denervated muscle fibers. And it is revealed by an increase in water T2 and is detected with STIR-T2 weighted or water T2 maps. In chronic denervation, the prominent feature is the fatty replacement. This is revealed by hyperintensities in the clinical T1 weighted sequences due to the short T1 of fat, or by hyperintensities in T2 weighted sequences, here due to the long T2 of fat, also resulting in an increase in T2 in global T2 maps, or by the chemical difference between water and fat with the Dixon sequences. Muscle global T2 and muscle water T2 are very different entities, and it's important to understand what they represent. When you apply a single exponential to the muscle signal decay, you determine the global T2, and this global T2 is largely driven by the fat content. This again because of the very long T2 of fat. So the global T2 is a measure of the fat fraction, very similar to what you can obtain with Dixon sequences. If you want to measure the disease activity, you need to determine the T2 of the water component exclusively. And to do so, you have to remove the fat signal by post-processing using dedicated algorithms. So the global T2 and the water T2 are very different biomarkers. The global T2 is a marker of the fat fraction. The water T2 is a marker of the disease activity, edema, inflammation, dystrophy, necrosis. In the context of denervation, the evaluation of the muscle atrophy is also of importance, with a preference to be given to the Dixon sequences for quantitation. There can also be a particular texture of the images with isolates of fat and normal muscle of different sizes distributed irregularly throughout the muscles, up to the point where the different muscles can hardly be distinguished. This is known as the neurogenic pattern, as opposed to the myogenic pattern, where the intramuscle fatty replacement is more homogeneous and the different muscle remain distinguishable up to a very late stage. And finally, diffusion MRI. NMR can measure the diffusion, which in essence is the mobility of the molecule along any particular direction. And in the skeletal muscle, because of the tubular shape of the muscle fiber, the diffusion is anisotropic. It means that the diffusion along the long axis of the fiber is much higher than perpendicular along the short axis. So the more anisotropic the diffusion is, the higher the fractional anisotropy, which is the ratio between the different diffusion coefficients. In an atrophic muscle, because of the reduction in size of the muscle fiber, one can expect to have a reduction in the apparent diffusion coefficient, which is a measure of the global diffusion, as well as an increase in fractional anisotropy. Initially, there has been relatively few muscle imaging studies in 5q SMA, and this for the simple reason that it was not really needed. In type 1, at a very early age, well, atrophy is predominant. In type 2 and type 3 patients at a later age, atrophy is associated with various degree of fatty replacement with a proximal to distal gradient. Adductor longus and semitendinosus are typically preserved. Muscle texture can be either neurogenic or atypical. With whole body imaging, the predominant involvement of the iliopsoas and also of the triceps brachialis has also been documented. It is only recently that an in-depth characterization of the skeletal muscle was performed by quantitative imaging in SMA. Here, in type 2 and type 3 patients, Well, the degree of fatty replacement was determined in different muscle groups of the thigh, was found to be more severe in the type 2 than in type 3, and also more important in older patients. Muscle diffusivity was reported to be lower, and fractional anisotropy was found to be higher as predicted for an atrophic muscle, again more severely in type 2 than in type 3 patients. Water T2, an indicator of disease activity, was however found to be in the normal range, and if anything somewhat lower in SMA patients. This is at variance with what has been reported in dystrophy and in myositis. Well, in all conditions, fat fraction is increased, at least in the chronic stage. However, in a dystrophic or inflammatory muscle, likely due to the fibrous swelling, mean diffusivity is increased and fractional anisotropy is reduced. This is the opposite in SMA in relation with atrophy. Water T2 is increased in the dystrophic and inflammatory muscle, while, as we've seen, water T2 remains normal in SMA. And if we add the global T2, which is another way to determine the fat fraction, well, it is increased in all conditions, at least at the chronic stage. These patients then entered a follow-up study. After 1 year, the water T2, which was normal, remained normal. The diffusion parameters, which were abnormal, remained stable, similarly as the cross-sectional area. However, the fat fraction increased by about 2%, and the contractile cross-sectional area decreased accordingly. Interestingly, the clinical functional scale, the Hammersmith and the MRC, were not able to detect any significant degradation during this 1 year period. This confirming the superior discriminant power of quantitative muscle imaging to monitor disease progression. So, in active muscle dystrophy or myositis, the higher the water T2, the more active the disease is, and then the faster the muscle destruction progresses and the fat fraction increases. It is not true in SMA, where muscle destruction develops while water T2 remains normal. This pointing to a different pathogenic mechanism being likely predominant in SMA, like the lack of neurotrophic factors or chronic disuse. In a dystrophic or inflammatory muscle, water T2 somewhat predicts and correlates the increase in fat fraction. However, water T2, which is an instant biomarker of disease activity, never correlates with the fat fraction itself, which is an integrative biomarker of what happened during the patient's life. And in SMA, well, these variables simply do not correlate at all. How is it possible then in relatively prestigious journals, authors state that the water T2 correlates with the fat fraction in SMA patients? And they show it in this graph, where what they call the water T2, well, very nicely correlates with the fat fraction obtained by Dixon. The explanation is simple. While the authors have used the right sequence to measure the water T2, they failed to extract the water component, and they have simply calculated the global T2. And if you remember, the muscle global T2 is just another way to determine the muscle fat fraction. So if you measure the fat fraction with two different methods, there's no surprise that you find that they are highly correlated. So what they call the water T2 is in fact the global T2. So a gross mistake that went unnoticed by the reviewers. So if you're asking why am I bothering you with all these NMR technical considerations, because I would like you to be able to read and to decipher publication and to be able to sort the false and the truth. Paper is without defense, do we say in France. Let's now enter the core of the talk and see how the impact of treatment in an SMA muscle can be estimated with imaging. All data published so far are after nusinersen treatment. In this study, what the authors have shown is that the higher the muscle destruction estimated by the qualitative composite mercury score at baseline, the lower the functional benefit obtained by nusinersen in type 2 and type 3 patients. A somewhat, trivial observation, I would say. Much more relevant is to look at the same quantitative indices that were used to characterize disease progression in the SMA muscle during natural history. This has been done by the same Dutch investigators on a similar group of type 2 and type 3 patients treated with nusinersen for about 1 year. They observed an improvement in the functional MRC score as well as an increase in the muscle strength in the adductors and the hamstrings. However, the muscle destruction, as evaluated by the fat fraction, continued to progress, and this at a rate that is very similar to the one observed during the natural history study. The steady progression in fat fraction is shown on this graph, and the association between functional improvement and an increase in fat fraction is nicely illustrated here and here. The discrepancy between the functional and strength improvement and the structural degradation is puzzling. It shows that nusinersen, while improving the patient's status, is not able to stop disease progression. The picture might not be as bad as it looks, because the increase in fat fraction is not associated with a corresponding decrease in contractile volume. This contractile volume remains stable over time, suggesting that the muscle destruction is somehow compensated by some positive trophic effect of nusinersen. The same observation had previously been reported, but on a more anecdotal mode in just 3 patients, where on the one hand the functional scores were stable or improved under nusinersen, while on the other hand, the fat fraction continued to increase in the thigh muscles. Here also there was a discrepancy between some functional improvements and the progression of muscle destruction in some territories. I am showing this study for the sake of completeness. After 2 years of nusinersen treatment, no change in fat fraction was measured in 2 SMA patients. The others claim to have detected an increase in muscle fibers number and fibers length based on diffusion tractography, an assertion that is hardly supported by the poor quality of the native images. Altogether, we have a relatively concordant body of evidence showing that at least in type 2 and type 3 SMA patients at a relatively old age, nusinersen, while improving the patient condition, is not able to stop the disease progression. Interestingly, similar discrepancies were observed with electrophysiology data. After 3 years of nusinersen treatment, while the upper limb function and the 6-minute walk test were clearly improved, there was no change in the electrophysiology assessment. The CMAP, the compound muscle action potential, or the MUN, the motor unit number estimates, both biomarkers of the muscle innervation. What about very young patients, type 1 patients, very difficult to examine in an MR scanner? Should we look for other complementary imaging methods? Well, certainly yes. The most promising is certainly ultrasound coupled with optoacoustics. The photoacoustic effect was described more than 1 century ago by Graham Bell. Some molecules, when they are hit by light at a particular frequency, absorb energy, vibrate, and emit an acoustic wave that can be captured by ultrasound sensors. And by scanning with laser light over a range of frequencies, the oxyhemoglobin, lipid, and very interestingly, collagen can be detected and imaged. The system is highly portable, and even if the light penetration limits the investigation to relatively superficial tissues, is much less of a problem in infant. And as you can appreciate on the right, at 800 nanometer, the hemoglobin isobestic point, well, the disorganization of the muscle vasculature is nicely depicted in an SMA patient, as well as the intramuscular accumulation of collagen is revealed. The data are very preliminary, but relatively young type 1 SMA patients could be investigated with MSOT, showing some degree of correlation between the functional scores and the images at 800 nanometer. Again, very preliminary, but the collagen content seems to be higher in a type 1 patient. And in accordance with the NMR observation, well, neither the lipid nor the collagen content seems to be improved by treatment. Of course, all this has to be confirmed by further studies on much larger patient groups. SMA is primarily a disease of the second motor neuron, so a direct investigation of the spinal cord is highly desirable. Nowadays, on modern scanners with dedicated sequences, the spinal cord can be precisely visualized, including the butterfly-shaped white matter and also the anterior and posterior roots, and this at least at the cervical level. As a general rule in motor neuron disease, the key imaging feature is the cord atrophy of the gray matter, and mainly in the ventral horns. Several studies have shown that in SMA patients, type 3 and also type 4, with a reduction in the cross-sectional areas, specifically in the gray matter at different levels of the cervical spine. About the response to treatment, the data are very preliminary, but in this patient with a progressive functional improvement, it may be that the cross-sectional area in the gray matter, and particularly of the ventral horn, has also increased. Of course, much work has to be done before any firm conclusion can be drawn. Peripheral nerves. It has been clearly demonstrated by MR neurography that there's a reduction in the cross-sectional areas of the peripheral nerves in type 2 and type 3 SMA patients. Correction by treatment might become another interesting biomarker of treatment efficacy. It can be similarly done with ultrasound neurography, including in much younger patients, with the indication here that early treatment with nusinersen in type 1 patient was able to preserve the nerve trophicity. Finally, a few words about the brain involvement. A number of brain anomalies have been described both in infantile onset and in later onset SMA patients. Their origin and significance is insufficiently understood to consider them as potential outcome measures in treated patients. To conclude, well, first, some take-home messages. In 5q SMA patients, the skeletal muscle alterations seen at MRI are specific and different than the ones in dystrophic or inflammatory muscles. Spinal cord, peripheral nerves, and brain anomalies are very well depicted by MRI. So far, we have still a limited number of MRI data in treated patients, mostly with nusinersen, mostly in older type 2 and type 3 patients. And in these treated patients, there is evidence of disease progression in muscle despite significant clinical improvement. Future directions. It will be to study larger populations treated earlier and for a longer period of time. We also need the development of novel tools for the evaluation of very young type 1 patients. It can be real-time high resolutions, spinal cord MRI, or improved artificial intelligence-based muscle imaging processing, or ultrasound-derived advanced tissue characterization, as we've seen with MSOT. Together with my grandchildren and my dog, let me wish you all the best for 2024. Спасибо за внимание.